Flow cytometry from pleural fluid shows no V events, zero CD20 positive cells. Most CD2 cells not expressing CD3, an abnormal finding. Normally around 30% of the T cells are CD8, not here. All CD2 cells here are CD4, not expressing CD8. Equally abnormal, CD5 T cells are not expressing the CD3. And many CD7 cells are CD3 negative, also abnormal, with significant decrease in CD7 expression. Almost all T cells are expressing CD4, not CD8. 13% of the T cells are CD10 positive, an abnormal feature for peripheral blood. Most T cells do not express CD3, only 25% of the cells expressing CD3, clonally expressing the T cell receptor alpha beta. The pleural fluid cell block immunohistochemistry is negative for CD20, all cells positive for CD4, and almost all cells negative for CD8. So we know now that this is a T cell lymphoma, probably a peripheral T cell lymphoma with abnormal expression of T markers. If you add 66% of CD4 cells plus 14% of CD8, you expect a total CD3 of 80%. This is not what is happening here. We only have 26% CD3 positive cells. So many cells are losing the surface expression of CD3 and the 26% preserving the CD3, clonally expressing the T cell receptor alpha beta. We already mentioned CD7 also significantly decrease. All these features, plus the clinical presentation, plus the eosinophilia, and the CD10 positive in peripheral blood in favor of a follicular T cell phenotype. So this is not a conventional PTCL-NOS, is an angioimmunoblastic T cell lymphoma. How we prove it? We also have the biopsy from 3 months before an axillary lymph node in a patient with multiple neck, axillary, and inguinal adenopathies. The H&E shows effacement of the normal architecture, born out of germinal centers, the prominent branching arborization of endothelial venules, a feature that is probably related with vascular endothelial growth factor. In fact, some oncologists are trying treatment with anti-VEGF and patients are improving. Neoplastic cells are predominantly small lymphocytes, occasionally large lymphocytes. The background is very rich in eosinophils, plasma cells, and dendritic cells. If we stain the dendritic cells, they are CD21 positive, CD4 strongly positive, CD2 strongly positive, CD5 also strongly positive. T cell follicular phenotype rule out, as we mentioned before, peripheral T cell lymphoma NOS. Best markers to prove that, the best one is CXCL13 and also CD10, BCL6 and PD1. You need at least 2 positive to confirm the T cell follicular phenotype for angioimmunoblastic T cell lymphoma. Here is the CD10, also positive and commonly positive in clusters around the endothelial vessels. Epstein-Barr in situ hybridization is commonly positive in 70% of the cases. You can compare here with the left side, that is the negative control. EBV is positive, and it is probably the reason for the monoclonal B cell proliferation in these tumors with rearrangement of immunoglobulins. B cell component is sometimes CD30 positive. Some oncologists request the CD30 because in positive CD30 they can try anti-CD30 medication. The karyotype usually shows many trisomies, deletions, not in this case. This case was completely normal male karyotype. So let's finish with a summary of the common clinical and laboratory manifestations of angioimmunoblastic T cell lymphoma. First, commonly preceded by angioimmunoblastic lymphadenopathy, preceded by bacterial infections, sometimes viral infections, EBV the most common, but also hepatitis C. Generalized lymphadenopathy, very common. Neck, axillary, inguinal lymph node, the most common. Hepatosplenomegaly, very common. Many patients hypergammaglobulinemia. Explain why in the background you see so many plasma cells and immunoblasts. Remember, sometimes the proliferation is not polyclonal, it's monoclonal, and you prove this with immunoglobulin rearrangement, that is the proof of B cell clonality. Some patients are in stage 4 with hepatosplenomegaly, lung infiltration, bilateral pleural effusion, ascites, and bone marrow involvement. It seems to be the case with this patient. Autoimmune disorders are very common. Eosinophilia, also very common. And finally, pruritic maculopapular skin rash.